So just briefly on our epidemiology, I think we all know that we're in the midst of what's called an opioid epidemic. In 2016, over 60,000 people died from overdoses. And just by looking at this graph here, just in the 16 years that it depicts, the rate of overdose deaths has actually tripled in almost every single part of the country except for a little scattered area in the Midwest. And at first glance, it's unclear why we are experiencing such a problem. From 2010, the opiates that we've been prescribing to our patients has actually decreased by over 15%. So what exactly is going on? Because it's not going away. Well, I love this graph because it explains the three waves in the rise of opioid overdose deaths, as well as the rate of addiction to opiates in general. So the first wave occurred in the 1990s, and this was a rise in prescription opioid deaths. Does anyone know what happened in the 1990s that caused this? Right. So the first thing was that OxyContin was introduced to the country and advertised heavily as being a non-addictive opioid painkiller. We know now that that's completely untrue, but the ads from Purdue back in the day are interesting to say the least. The second thing that happened in the 1990s was that pain became the fifth vital sign in hospitals, and that created pressure on everyone to treat pain as aggressively as they could so that when JCO or whoever evaluated the numbers, it looks like we were doing our job. In 2010, things changed. Who knows what happened in 2010? Right, and why? So two reasons, again. First, OxyContin became tamper resistant. It became much more difficult to change OxyContin into an abusable form that you could inject. Secondly, our prescription monitoring programs became much more prevalent. Nowadays, I think 49 out of the 50 states has one, and this gave doctors, the ability to see which prescriptions patients were filling that were controlled, noticing if they were doctor shopping or going to the emergency room multiple times for refills, and that started the trend of reducing the prescription of opiates. That had an unintended consequence. We were able to reel in the number of opiates we prescribed. However, people who were addicted had to turn to the illicit market to continue their addiction. Not only heroin, but then fentanyl and other synthetic analogs started infiltrating the market, and especially with fentanyl appearing in basically everything, the opioid deaths have dramatically risen. And just looking here, opiate deaths in general have increased over the past 15, 20 years, but what's taken over is the fentanyl and the fentanyl analogs like carfentanil as well. I've had patients come in who say that they're abusing heroin, and when we test their urine, there's no heroin at all in their urine. It's depending where you are in the country, it's 100% fentanyl or carfentanil. And of course, we can't forget about the other substances. Even though the addiction medicine professional focuses on the opioid epidemic, there are plenty of other addictions there. Alcohol, for instance, 90,000 people die annually from alcohol-related causes, so that is almost twice as much as those caused by opiates. And it's the third leading preventable cause of death, just behind tobacco and obesity. And about 50% of our liver deaths are associated to alcohol abuse. And you can see here in this graph that there's about 7 million people in the U.S. who are addicted to illicit drugs, but twice as many are addicted to alcohol, and even twice as many as alcohol is our tobacco. And this is all more than cancer or HIV. And it's very costly to society. So there's reasons related to that why we should be concerned. So what exactly is addiction? You guys have an idea, I'm sure, of what it is. But first I want to do a thought experiment this early in the morning. So I just want to see a raise of hands. Who thinks hypertension is a disease? Okay. Now, who thinks addiction is a disease? Okay, very good. Now, who thinks addiction is a disease in the same way as hypertension? Right. There's a couple, but I can tell that a lot of you are hesitant, which is completely normal. So my answer to that, and people have different answers, is that it sort of is the same as hypertension. Because it involves choice initially. You can't become addicted unless you choose to use the drug for the first time. And it can be controlled, at least temporarily. If you place a drink in front of an alcoholic, but then put a gun to his head and say, if you take that drink, I'm going to shoot you, they can at least temporarily choose not to take that drink. And it involves behavior, which has a whole history to it. But it's because of these behaviors that the biggest counter-argument to the disease model is the choice argument. And it's the most common argument, and basically they see behavior as a choice. Cancer patients do not choose to have cancer, but they say that addicts choose to use drugs. And this guy, his name's Richard Jones, and he's from Ohio, and he was discussing in a Trump rally that he doesn't want to give naloxone to his police officers because it's $37.50 a dose, and also he feels like it's a risk to put his police officers in a situation where they might get injured. And what he says is this: I'm not the one that decides if people live or die. They decide that when they stick that needle in their arm. Anyone who's had an addiction can say that it is no choice when they do that. However, because it is a behavior, there are so many people in the country and the world that see this as being a controllable issue. And throughout the centuries, we've seen bad behavior as being a moral defect. I don't know if you guys ever have heard of general paralysis or general paresis of the insane, but I explain, this is a medical article from the 1800s that is explaining a disease that they had no idea what was causing it. And they basically say that it's a moral agony, an emotional overstrain, and they attribute it to all these different issues having to do with the patient's life. And they describe the disease as this: personality changes, impaired judgment, mania, pupillary changes, which is a hint, delusions, confusion, and death. Can anyone guess what they're describing? Yep, syphilis. So before they knew what syphilis was, they attributed the disease to being a moral defect. And I find this to be very similar to how some people are dealing with addiction today. So what is addiction exactly? ASAM, which is the American Society for Addiction Medicine, defines it as a primary chronic disease of brain reward, motivation, memory, and related circuitry. It's a pathological pursuit of a substance. So that means that despite harm to themselves and others, they continue to use. And it involves cycles of relapse and remission, just like basically any other chronic disease that we have that we know about. And it is progressive if not treated and can result in significant disability or premature death. So it's of the utmost importance that we address it as soon as we can. The DSM-V has specific criteria for substance use disorder. I won't go through all of these. You certainly can look it up on your own time. But I do want to notice that there's two criteria here: withdrawal and tolerance, that we see frequently in our pain patients. And based on the criteria, you only need 2 to have a mild substance use disorder. So what makes that different between a substance use disorder and dependence is the fact that it's clinically significant impairment or distress. I don't think I've ever seen a patient that only has just 2. There's at least like a loss of control or craving, but technically you could just have 2. Just a mnemonic, W chart uses all the first letters of the, it's a stretch, but helps me remember. All right. Okay, so currently we see addiction as a biopsychosocial model. Biological, genetics, neurobiology primarily is where we're studying. Psychological, of course, with our psychiatric comorbidities. We have a lot of personality disorders in this population. And then a lot of social aspects as well. So in order to treat the patient completely, you need to address all 3. The neurobiology can be quite detailed, so I'm just going to give you a very brief introduction to this. But essentially, addiction involves the midbrain, which involves things like the amygdala, the hippocampus, the nucleus accumbens is a big one. And it's responsible, it's your primitive brain, so it's responsible for pleasure and processing of information. Then you have your prefrontal cortex, which is really, a newer part of the brain that allows us to make decisions, control impulsivity, that sort of thing. And they communicate via dopaminergic pathways. This is actually a bidirectional arrow. They communicate within each other, and when addiction takes hold, that communication is essentially completely stopped. So it's very interesting to see a patient new into recovery or someone still in their addiction. They have no awareness of what they're doing. Trying to explain to these people how their addiction is harming themselves, it doesn't matter because their prefrontal cortex is basically offline. So to reiterate the point, the pleasure system has just taken over and gone rogue. For instance, you see this piece of chocolate cake, your dopamine system guaranteed just had a surge. And then your prefrontal cortex that's telling you, don't eat that cake, you've gained some weight, you're starting to feel full, no more. So you're free to eat as much chocolate cake as you possibly could. In addition, what complicates things is that psychiatric illness is extremely common in this population. It's estimated that about 60% of those with opioid use disorder have a co-occurring psychiatric illness. The rates of addiction and schizophrenia, for example, are 70 to 90%. So it's important to treat their comorbidities. PTSD, history of abuse, especially as a child, is very common. You have your personality disorders like borderline and antisocial, the conduct disorder that happens in children. And you see poorly developed coping skills and immaturity in many of these patients. They've started abusing drugs before they've been able to fully develop their prefrontal cortex. Their prefrontal cortex isn't fully developed until at least age 22. And it seems as though once they start abusing drugs, the development of the cortex is actually stopped. And then there are many social influences on whether someone develops an addiction, their socioeconomic status. It crosses all socioeconomic statuses, of course. Things like unemployment, homelessness occur either as a result of the abuse or even prior to the abuse. If people are surrounded by their peers who use drugs, they're more likely to use it too. And a lot of these people have very limited support systems and isolate themselves. So the addiction professional treats the whole person, of course, both medically, emotionally, and socially, and we recruit as many people as possible to give each patient the full treatment. So what's the treatment for addiction? Our goals are to, number one, keep the patient alive. Before we start any psychosocial treatment, counseling, that sort of thing, we want to get them on medication. It's actually the medication that's been proven to save lives more so than counseling, There has actually even been some studies questioning whether counseling is even effective for anyone, but that's an area of debate. Once you get them stabilized with medication, then you can improve their other aspects of life, help them get a job, help them complete their education, work on their very commonly HIV, hepatitis C, that sort of thing, and ultimately improve their suffering. So there are 3 approved medications for the treatment of opioid use disorder. First is buprenorphine, with or without naloxone. This is called Suboxone, which I'm guessing most of you have heard of. It's a very interesting drug because it's a partial mu agonist as well as a kappa antagonist. And so it's thought to be safer because there's a ceiling effect. It's thought to be less likely to cause euphoria, less likely to develop tolerance, and because of the kappa antagonist properties, it's actually being used as an antidepressant in Europe. It comes in multiple formulations. Most recently, we now have an injectable form that lasts for 1 month, and that reduces the probability of diversion or misuse. But unfortunately, you have to be careful when starting this medication because if they have full agonist opiates in their system and you give this too soon, they will go through a full withdrawal. And even though the naloxone is put in there to avoid abuse of the medication, I have known people to dissolve it and inject it, and they just suffer through the withdrawal for an hour, so they get the high later. Secondly, methadone. At least in New York, you can only treat patients with an opioid use disorder with methadone at a methadone maintenance treatment program. And the reason for that is if you have a patient coming in for a prescription of methadone and they typically need higher doses than that for pain, let's say 80 to 120 milligrams per day, maybe even up to 200 or more, you're not going to send them home with a prescription for 300, 500 pills of methadone per month and risk the consequences of them abusing it or diverting it. Typically, methadone is given just once a day, unlike the pain, the way you treat pain, which is multiple times a day. And if you give it in a large dose once a day, you control their cravings for 24 hours. The patients need to come in every single day to receive their treatment. This is great for people who have very little social support, unemployed, because they have the time to come into the methadone program, participate in the counseling and groups that they have there, and they can be watched more closely. Of course, methadone can be a dangerous drug. You have to worry about the variable half-life, the prolonged QT, and there is still a possibility for diversion. I met someone who put a cotton ball in her mouth and took their methadone, and then they would sell the cotton ball outside of the clinic. Finally, there's Vivitrol. Vivitrol is naltrexone, which, as you know, is an opioid antagonist, and it comes as either a pill or a once-monthly injection. And it can work very well in terms of curbing cravings. It works for alcohol, too. It's not abusable. You have no euphoria from it. But patients, for various reasons, do not like this. They want to, have a medication every single day. And so you have poor compliance. It's best for maybe healthcare professionals who are very motivated to stay sober. And this is not good for people with pain because it blocks the opiates. And it has been proven time and time again that treating people with this kind of therapy reduces heroin overdose deaths. Suboxone, methadone, Vivitrol, they all have very similar success rates. Much higher success rates than just abstinence alone. Briefly, you've probably heard that in order to prescribe buprenorphine for addiction, you need a special DEA number called the X number. And it's very easy to get. You have to have a current state medical license, have a DEA license, and either already be board certified in addiction or take an 8-hour course. You can take it all online for about $200, and they'll give you the ability to prescribe the buprenorphine. And when you start prescribing for 1 year, you're only allowed to prescribe for 30 people. After 1 year, you can increase to 100, and if you're extremely prolific, you can increase it to 275. As similar to the opiate use disorder, there's 3 approved medications for alcohol use disorder. And these aren't as successful as the treatments for opioid use disorder, but there still is some success. First, we have Campril, and it's hard to get a patient to do this because they have to take 2 pills 3 times a day, and the results are modest, but essentially balances the neurotransmitters GABA and glutamate, which are affected in alcohol abuse. It does reduce the cravings, and it's great because so many of these patients have liver disease, and it's excreted 100% from the kidneys. Naltrexone, once again, can actually be used for alcohol use disorder. Vivitrol was first approved by the FDA for alcohol abuse, not opioid abuse. And it actually supposedly lessens the buzz from alcohol. But like I mentioned before, the compliance is an issue, and you can't give it to people with liver disease. Finally, there's antabuse. Antabuse is horrible. You can't get a patient to be compliant with this, so it's no longer a first-line therapy. Antabuse basically inhibits your aldehyde dehydrogenase, which causes accumulation of acetaldehyde, making you extremely sick. And no one wants that to happen. So unless someone's there every day forcing the patient to take the pill, they're not going to do it. And you could even end up in the ICU with such severe reactions. So if someone has like a history of heart disease, it would be a disaster if they start vomiting uncontrollably. We're in the works for using other substances to treat the alcohol use disorder, like baclofen, gabapentin, etc. These have not been approved by the FDA, but there's plenty of doctors using them with some success as well. The other addictions. We do not have good treatment for any of the other addictions aside from tobacco, which I'm not addressing here. Cocaine addiction, marijuana addiction, methamphetamine abuse and addiction. There are no FDA-approved medications for these. And so in a case like that, our psychosocial treatments are the most important. Of course, we have different types of individual counseling and group therapy. Intensive outpatient treatment in which the patient comes several times a week, up to every single day, and engages in individual and group counseling therapy with or without psychiatry. You have your rehab programs where you stay for a month to 6 months to 12 months, and then 12-step recovery, which is shown to be extremely beneficial for patients, especially those who isolate themselves. And treatment makes sense. So people do recover from this. About 30% are able to be sober a year later, which might not sound like much, but I mean, if you're batting an average of 300, you're considered to be really good, right? And it improves dramatically with your opioid agonist treatment. At least 50 to 60% are successfully sober 1 year later on that treatment. And it's beneficial for everyone because it saves money. Both in terms of related crime expenses, but also from the standpoint of paying for the associated diseases. Okay, unfortunately, even though there are so many people with addiction, only 11% are receiving help, which is truly unacceptable. And there's multiple reasons for this. We do a horrible job of screening our patients. Even just a simple question of how many times do you drink in a year could give you a clue as to what's going on. These patients do have limited access to medical care. A lot of them are uninsured. They have a poor social support network to help them find the help that they need. They have a lack of education about addiction, both the patient but also family members. They might feel ashamed about the addiction. There are providers out there who will refuse to treat patients with addiction. I've heard horror stories about primary care doctors discharging patients because they have a history. There aren't too many addiction professionals in the world, which is starting to change. The psychiatric illnesses, of course, if they're uncontrolled, can get in the way. And there's a lot of discrimination and shame that these patients feel. So briefly about discrimination, I don't think there's one person suffering with addiction who has not felt discriminated multiple times. And it's not only a shame that they feel imposed by others, but it's a shame that they put on themselves, and it's an extremely painful experience for them. The patient is experiencing so many difficult emotions that they're treating with their addiction that it's just a vicious circle. They are not pleased with themselves. They are not happy at what they're doing. They're extremely embarrassed and ashamed, and as a result, it's hard to get them into treatment. So when we're talking to them, we have to be very careful about our language. And when we're talking about these patients with each other, I have noticed many times, not saying among you guys, but among other medical professionals, saying some very stigmatizing things. For example, in my psychiatry rotation during my fellowship, I was talking to the psychiatrist about addiction, and he goes, you know, these patients that we have that are Medicaid, that come here who are homeless, for them, for addiction, I get that. But I had a patient recently who was a physician and an alcoholic, and really he should know better. And I just wanted to strangle him, because it's not about knowing better. Once it happens, you have no control. So what does the addiction physician do, just so you guys know? We screen for problem use, we treat as much as we can, and then we have to know when to refer, because sometimes the problem is just beyond our capabilities. We manage withdrawal in the hospital most times, but also as an outpatient. We try to either reduce or eliminate the drug abuse behavior, and we treat co-occurring illnesses as possibly as we can. Hepatitis is very common, as well as the psychiatric illnesses. And we're also responsible for educating the community, doing lectures like this, but holding training for the community to know how to use naloxone. Many places you can just go to the pharmacy without a prescription and pick up naloxone from the pharmacist. You hold support groups for family members, and really our goal is to destigmatize the disease. How do you become an addiction professional? Well, there's two official ways you can do it, but there's plenty of people out there who haven't followed this pathway. Essentially, you either have to go into psychiatry or absolutely anything else. Even like pathology or dermatology, you could do this. And after you do this, the goal is that you do a fellowship. Now, until 2021, people are allowed to do the practice pathway because this is such a new field that if you've seen so many addiction patients, you're allowed to sit for the board exam without doing the fellowship. But starting in 2021, you will be required to do an addiction medicine fellowship, which will be ACGME accredited at that time. Take the examination, and then voila, you're a board certified addiction specialist. Addiction specialists work absolutely everywhere. You can see them as an outpatient clinic, like at the TOSA Center where I am. The methadone maintenance programs, rehab and detox units. We work in the hospital consulting for people who don't know how to manage withdrawal. Pain management clinics are now starting to hire addiction professionals because it's so prevalent there. And of course, they can work in laboratories doing research, or government agencies like the DEA or the NIAAA and all those other acronyms that we'll never remember. But there's a lot of research and policy going on. So, just to wrap it up, I've given you a lot of information, and I don't expect you to remember most of it. But basically, how does this apply to you guys as anesthesiologists? It might be obvious, but it might not be so obvious. So first of all, these are our patients. You know, what do we do with the pre-op patient on Suboxone? It seems like the belief that we need to hold Suboxone for 3 days is pretty prevalent, but that's actually a risk for addiction, people suffering from addiction, that might be too big of a risk to take. More and more research is coming out that 3 days is much too long. Just 12 or 24 hours is perfect before the patient undergoes surgery. Dr. Pinkerton mentioned the intoxicated patient that was rushed to the emergency room. What do you do with them? What do you have to worry about afterwards? You have a delirious patient in the PACU. You have no idea what's going on. You have to consider withdrawal as part of your differential. Or if you have someone in the ICU with extreme pain, but guess what? They got their Vivitrol injection a week ago. What are you going to do? They're not going to be able to respond normally to opiates, so you have to consider your alternatives. And finally, for those OB folks, you have a pregnant patient either on heroin or even methadone. What are your concerns and worries with them? Of course, too, these are our fellow human beings, our family members, our friends, and even our colleagues. Especially in the specialties of anesthesia, emergency medicine, and psychiatry, the rates of addiction are higher than the national average, and we need to be kind to each other. And ultimately, it's a public health crisis. We're having chronic pain patients suddenly cut off from opiates rather than being appropriately tapered. This is happening most in the primary care setting. We have physicians who are being arrested and incarcerated for their prescription practices. A lot of them, the prescription practices are horrendous, but there are some where it's more questionable. The average life expectancy in the U.S. has actually decreased for 2 years in a row. I think that it's leveling off as per last year, but the reason for the drop in life expectancy is because of all these overdose deaths. And then whether we like it or not, medical and legal marijuana is coming. And that's a talk for a whole nother time, but it's interesting because even though the federal government sees it as a Schedule I drug, state legislation is legalizing it on a state-by-state basis. And even though we're using it as a medical substance, it hasn't gone through the rigorous testing that drugs normally do. So we have no idea what kind of crisis is going to happen if we do. We legalize tobacco and alcohol, and those are some of the biggest causes of disease and addiction today. So shout out to this movie, A Star is Born. I absolutely love it, but it might seem ridiculous, but I think it does a great job of depicting suffering with addiction. And Lady Gaga says to Bradley Cooper when he's in rehab, I won't give away any more, but she says, it's a disease, this is not your fault. And all of our patients with addiction deserve to believe this and hear this from each one of us. They don't hear it ever, and they certainly don't believe it. So I think even just making a simple statement such as this can really have a profound impact. So that's it for me. I have my contact information here, including my personal information, which I know is taking a risk, but I want you guys to be able to contact me at any time, whether it's an issue with your patient, with a colleague, with a family member. I want you to feel like you can reach out and get some advice, and I can help you through the process. And so that's it. I'm happy to take any questions.